Hello and welcome to the next Newborn Toolkit webinar. Today we're looking at better breathing for tiny babies. What's next for antenatal corticosteroids and caffeine? We encourage you to please introduce yourself in the chat, sharing where you're joining us from today. Um, Next slide, please. So welcome to the webinar. So today, the Newborn Toolkit focuses on moving faster together, so sharing multi-country, multilingual learning for high-quality small and sick newborn care. In 2025, we had over 62,500 unique users from 198 countries and territories worldwide. Currently on the Newborn Toolkit platform, there's over 1,000 tools in 15 different languages with technical content available in English and French. We also host linked communities of practice to accelerate change. Next slide, please. So today we're looking at better breathing for tiny babies, what's next for antenatal corticosteroids and caffeine. This is part of our webinar learning series centered around the 10 core components for health systems change. We encourage you to please sign up to our newsletter, to follow us on our social channels, including Blue Sky, LinkedIn, and Facebook for updates on different events, news, and activities engaged by the Newborn Toolkit. Next slide. And just to share, this webinar is an update on a similar topic that we hosted in 2023. So we're looking at it, the webinar 3 years on today. The focus was newborns and caffeine. So if you're interested in looking at kind of where we came from to where we are today, please check out this webinar on our website as well. Next slide. And sharing a few upcoming webinars we encourage you to join. So on the 14th of April, we have another webinar on referral systems and linkages to maternal care. 12th of May for World Kangaroo Mother Care Day. We'll be hosting a webinar linked to this topic as well. So we invite you to please come join these webinars, and we're sharing some exciting updates and some more examples of cross-country learning linked to these two areas. Next slide. Donc, bonjour et bienvenue à tous nos participants parlant français. Si vous voulez écouter le webinaire en français, s'il vous plaît, cliquez sur le bouton d'interprétation situé sur la barre de menu de Zoom pour accéder à la canal français. On a aussi quelques webinaires à venir. Le 14 avril, le système de référence et lien avec les soins maternels. Et le 12 mai, un webinaire à l'occasion de la Journée mondiale des soins maternels kangourous. Donc, nous vous invitons à nous rejoindre pour ces webinaires. Et si vous voulez vous introduire dans le chat en indiquant votre nom et d'où vous venez aujourd'hui. Next slide. So without further ado, I'd like to introduce our host for today, Professor Chinyere Ezeaka. She's a professor of pediatrics at the College of Medicine, University of Lagos, and Lagos University Teaching Hospital. She previously was the past national president of the Nigerian Society of Neonatal Medicine, and she is the NEST 360 clinical lead for Nigeria. So we're very excited to have her here today as our webinar host. And without further ado, I will hand over to Professor Chinyere.
Thank you, and merci beaucoup, Lauren. Thank you. Good morning, good afternoon, and good evening, everyone, depending on which part of the globe you're joining us from today. Welcome to this multi-country, multilingual learning session for us to deliver quality newborn care for our sick and small newborns. This promises to be a very informative session. Our topic today is looking at a very critical area for newborns. Better breathing for tiny babies, what next for antenatal corticosteroids and caffeine. And we have a lineup of experts to do comprehensive justice to this topic today. How do we optimize antenatal corticosteroids and caffeine to give our small and sick newborn babies the best start in life? Join us today as we explore the latest evidence, implementation research, and what is next. And we have big on market shaping for caffeine and antenatal corticosteroids to be to be available and affordable in a harmonized fashion. So, distinguished audience, we have our first speaker for today, who is Professor Josh Vogel. He is a perinatal epidemiologist and a public health researcher. He is a senior principal research fellow at Bonnell Institute in Melbourne, Australia. And he's also a co-program director looking at women's, children's, and adolescent health. He's also a co-lead for the Global Women's and Newborn Health Group. And he will be discussing our WHO recommendations on antenatal corticosteroids. What is the evidence? So Professor Joshua will be seeing him in a video. We'll be listening to him in a video presentation. Thank you. And thanks again for joining us. And bienvenue tout le monde. Thank you. Over.
Hi, everyone. Thanks very much for the opportunity to speak a bit about WHO's recommendations on antenatal corticosteroids. My name's Josh Vogel. I'm Co-Program Director for Women's, Children's, Adolescents Health at the Burnett Institute in Melbourne. And I was the evidence synthesis lead on the creation of these recommendations. So very happy to share some information about them with you all today. These recommendations were actually an update of recommendations that were previously published in 2015, but the update was triggered particularly because of some new trial evidence on these recommendations, which emerged from a WHO-led trial called the Action 1 trial, which I was also closely involved in. I just want to start by acknowledging the huge group of people that put together these WHO ACS recommendations for various organisations, and of course led by colleagues at the WHO from both the maternal and newborn health areas, and then myself and a number of others supporting this work in terms of assembling the evidence. I don't want to dwell on WHO's process for developing recommendations, but just to say that there is the use of the GRADE approach to ensure that all evidence is considered explicitly and systematically. That evidence is not just looking at evidence of effects, like we see from systematic reviews of quantitative evidence, but also understanding people's values, acceptability, equity, and feasibility considerations, and also resource and cost effectiveness considerations as well. The key message from these recommendations is that steroids are recommended for use at 24 to 34 weeks gestation when certain conditions are met. In this case, we want to know that the gestational age assessment is accurate, that we know we're giving this therapy to the right women in terms of gestational age lower than 34 weeks. We want to identify women in whom there is a high likelihood that preterm birth will occur in the next 7 days, and that there's no clinical evidence of maternal systemic infection. We also want to be using this intervention in settings where adequate childbirth care is available, so that those women who are truly at risk of imminent preterm birth are well recognised by trained and well-supported providers, but also that those women are giving birth in a place where the preterm newborn can receive that critical early life care, be it resuscitation, KMC, thermal care, feeding support, and infection detection, treatment, and respiratory support as well. I mentioned the Action trials. This was a large multi-country trial to determine the efficacy of antenatal dexamethasone. This trial was run because there had been doubts raised about the efficacy of steroids in low-resource countries emerging from a prior cluster randomised implementation trial called the ACT trial. It was a concern that potentially the steroids were not effective in these settings, or they could be potentially harmful. So this was concluded a couple of years ago, and fortunately showed what we had all hoped it would, that steroids are clearly efficacious in terms of preventing newborn death without causing harms to mother or baby, provided that they're used in settings such as those that I mentioned in the ACS treatment criteria earlier. In this trial, we were randomising women from 26 to 33 plus 6 weeks of gestation, all of whom had had a gestational age estimate based on ultrasound. And women were randomised to a course of IM dexamethasone every 12 hours to a maximum of 4 doses. And if required, a single repeat course could be used if required. The comparison was an identical placebo regimen And we were following all mothers and babies up to 28 days of life to ascertain whether there was a true reduction in mortality amongst those babies. The trial, in terms of its
No, but
implementation, went quite well. We had good uptake of quite high adherence to randomized therapies. However, what's interesting is that a lot of women delivered before they were able to complete a full course. So, actually, only just over half of the women in the trial got all 4 doses of the first course. There were relatively few women who required a repeat course. This is just an excerpt of some selected outcomes from the trial. What it showed was that there was a significant reduction in neonatal death at 28 days with the steroid-exposed group, and that the safety outcome, which was looking at possible maternal bacteria infection, we didn't see any differences between groups in terms of that safety outcome. This was for a non-inferiority hypothesis. If we look into the secondary outcomes, you can see that there was significant reductions in early neonatal death at 7 days and also severe respiratory distress at 24 hours, which is overall quite suggestive of what we know to be the mechanism of action of steroids, that its benefits and mortality reduction are primarily related to respiratory related benefits. What was surprising, a bit unexpected, was that the measurement of hypoglycemia showed that at 6 hours it was actually a high rate of hypoglycemia in the placebo group. However, hypoglycemia over a longer time period showed no differences. So our sense is this is probably somewhat artifactual, but again points to the importance of ensuring that good feeding and glycemic control in preterm newborns is very, very important. So in conclusion, this was a trial of 28,000 women in 29 hospitals, showed a significant reduction in mortality with antenatal dexamethasone, and those benefits were observed even though many participants did not receive a full 4 doses of trial medication, and the number needed to treat was 25 to prevent 1 newborn death. I won't go into the evidence for all the different recommendations in the guideline, but they do recommend that steroids is used regardless of single or multiple birth. You should use it if P-prom is present, provided there's no clinical signs of systemic infection. And it can be used in women with gestational diabetes or any form of diabetes, provided that maternal blood glucose control measures are in place. And also it should be used in women with hypertensive disorders or when an FGR fetus is expected. The recommendations, though, advise against using it in women with chorioamnionitis. There's evidence that that can cause harm. And also, we currently don't have enough evidence to suggest that post 34-week steroids should be used routinely, although there are ongoing trials in this space, including the Action 3 trial, which is looking at late preterm steroid use. There's no evidence to suggest at the moment that one form of steroid is superior to another, and there have been head-to-head trials. The advantage with dexamethasone being its wider availability, its lower cost, and it's actually listed on the WHO essential medicines list for this indication. So provided that it's used in a divided dose regimen and administered to women who have a high likelihood of giving birth preterm, that's where the benefit was seen. In terms of impact and implementation, we'd really encourage that all stakeholders look at their clinical guidance in their own hospitals, their own states, their own countries, ensuring that the necessary commodities and equipment and supportive training are available to healthcare workers in those settings, and thinking critically about the settings in which steroids are routinely used is proven to be very, very important. And of course, no behaviour change intervention will work without ongoing support in terms of refresher training, monitoring clinical performance, audit and feedback, and so on. The guideline elaborates on some different aspects of actually implementing these guidelines. I won't get into this here, but just to say that we're seeing the benefits of steroids maximised when one is in the right setting, it's administered to the right women at the right time. And in order to ensure that, we need to put a lot of mechanisms around the safe and correct use of steroids. So there's a need to think about this from a health systems perspective. Just to give you an example, we've always thought of ACS as being a very effective intervention, but it's also part of a larger package. There's a number of other interventions we recommend in favour of for women at risk of preterm birth, and indeed preterm babies need a lot of interventions and care around them to get the best possible outcomes. And that's on a background of other broader public health efforts to ensure that women are attending antenatal care early, that women are reaching facilities for childbirth, and that we can ensure that the right preterm birth interventions are available where they need to be. I just want to close with a couple of comments on research priorities. One is that the guideline identifies a number of questions where we do need more evidence, and those questions fall particularly into two buckets. One about how and where we can safely broaden the use of ACS. We may not necessarily get the same level of benefit that we see in the early preterm group, but there's certainly cause for expanding our efficacy investigations in that space. And the other is whether we can maximise the benefit and minimise the harm. For example, finding minimum effective doses, optimal regimens, optimal exposure durations. And I think a big question mark is what the long-term outcomes of steroids are in steroid-exposed babies. That's certainly in low middle-income countries a highly under-researched question. But as this broadening of steroids is explored and looking at more late preterm exposure, one needs to consider these long-term outcomes, I think, very, very carefully. So thanks very much. Sorry I can't be there in person, but hope you get something out of these guidelines and are able to implement them in your settings.
Thank you very much. Thank you so much, Professor Josh, for setting the pace with this very informative presentation. Professor Josh has told us that the WHO recommendations for antenatal corticosteroids. Where is the evidence? And that we have seen. And he went on to speak about antenatal corticosteroids must be given to the right woman at the correct time. So we're looking at women within gestational age 24 to 34 weeks who do not have chorioamnionitis. And we should not forget to bundle antenatal corticosteroids with other key interventions for newborn. This commodity is key, and went on to talk about the trial using dexamethasone as for early preterm birth in low-resource countries. And he went on to recommend that countries should look at their guidelines, have these commodities available, equip the facilities with it, and have some behavioral trainings and capacity building around this so that we're sure it is given to the right woman at the right time. And at this point, we'll move on to thank you again, Professor Josh, for this very informative, brilliant presentation. We'll now get to the next talk today, which is looking at how do we get this caffeine available? And we'll have two presenters from CHI. One is Musleehat, who will give the first presentation, and then Devon Cain. Musleehat is a senior manager at the global market team at Clinton Health Access Initiative. She leads product access for maternal and newborn health commodities. And she's a senior, while Devon Cain is a senior manager on the women's and newborn health team at CHI and leads efforts to expand the access to life-saving newborn care interventions and prevention of stillbirths. So you're welcome to this next presentation, and we'll start off with Musleehat. Thank you. Looking at expanding access to caffeine citrate in fragmented government finance markets. How do we get caffeine available? How do we make it affordable and sustainable? Over to you, Musleehat. Thank you. And Devon, thank you. Over.
Thanks, Chinyere. Devon is going to kick us off from the CHI side. Go ahead, Devon.
Okay. Hi, everyone. I'm Devon Cain. Together, Musli and I will walk you through our work to support increasing access to caffeine citrate. And so starting here, preterm birth is the leading cause of death among children under 5 globally, and apnea of prematurity, or AOP, is one of its most common and dangerous complications. Caffeine citrate is the WHO recommended first-line treatment for AOP with strong evidence behind it, and it's one critical piece of the broader respiratory care bundle that includes antenatal corticosteroids, oxygen infrastructure, and CPAP, among other products and equipment. Respiratory care itself being just one part of the postnatal care system that small and sick newborns depend on. But caffeine citrate is an important part of that puzzle, and WHO recommends it for treatment, prevention, and use and extubation of preterm infants. And it has a clear clinical advantage over the older alternative aminophylline, including a longer half-life, better oral bioavailability, a wider therapeutic index, and fewer side effects. But despite that strong evidence base, there are a number of barriers that limit access, especially in lower middle income countries, from health system readiness and provider awareness to registration and procurement challenges. And one of the other barriers is cost. So despite having similar production costs to aminophylline, caffeine citrate is often significantly more expensive in global markets. And that's a market challenge driven more by market dynamics than by what it costs to produce. Next slide. To better understand the scale of the access gap, CHAI partnered with researchers and institutions across 5 lower middle income countries to conduct a landscape evaluation of caffeine citrate availability and use in newborn care. And the findings that were published in 2024 confirmed what we were seeing on the ground, that despite being a proven, safe, and effective treatment, caffeine citrate remains largely unavailable in the countries where it's needed most. And this evidence base really helped sharpen our understanding of where the barriers were and informed the market shaping approach you'll hear about next. So I'll hand it over to Musli to talk through the next slide.
Thanks, Devin. As she just mentioned, the landscaping we did really revealed some of the key barriers that we saw. So at the baseline in 2022, the landscaping happened that year and several years before. What we saw were 2 interconnected challenges. On the demand side, the market was highly fragmented. Caffeine was missing from policy documents like essential medicines list and was not being tendered in most of these countries. And there were also significant knowledge gaps amongst frontline providers, and then inconsistent guidance on dosing and formulation. On the supply side, there were a limited number of quality assured manufacturers within the African market, and that meant little price competition. Also, there were fragmented order volumes, which made it hard for suppliers to really leverage economies with production. And then there were also complex distribution channels, which led to markups and ultimately further increasing the price for the end users. And just with the nature of the market, there's not as much funding on global funding from donors on newborn commodities. So country governments are the ones that really determine how products like these get procured. And this really means that any sort of work that's being done to increase access to caffeine and other maternal newborn health products should be embedded in government systems. And government ownership is really at the forefront. Over to the next slide, please. So given that context, we developed an approach really focused on a few key areas. First, increasing market visibility, aggregating demand signals across different countries so that suppliers could see the true scale of the opportunity. And then this also enabled more productive pricing conversations. And then also ensuring there were demand generation investments across countries and that these were government-led and embedded in these country systems, things related to guideline updates, EML updates, quantification processes, and also training plans for healthcare workers to ensure that adoption of caffeine would actually be sustained across these countries. Thirdly, we were also flexible and ensured we leverage growing donor support and country interests as it emerged. So there were particular country governments, for example, Kenya, that were there were just a lot of momentum on caffeine, and this was a product the government was excited about. Fourth, we also supported targeted catalytic procurements. These were small strategic purchases to jumpstart training and also for there to be a seed stock and facility so that healthcare workers could actually use caffeine and then demand it. And this also opened the doorway for engagements with manufacturers as well. And overall, these different strategies were targeted at a few key outcomes. One, more affordable pricing for caffeine citrate, a healthy and competitive marketplace, and then ultimately expanded access for patients through routine health systems. Over to the next slide, please. I mentioned Kenya earlier, and this is an example of the work that we did with caffeine in Kenya. We started with a market survey to build an investment case for switching from aminophylline, which was much cheaper, to caffeine citrate. So there was work supporting updates to the EML, revising national guidelines and algorithms, and then integrating caffeine citrate into newborn curricular. We also worked with one of the suppliers and facilitated a negotiation of the price, which led to 73% price reduction, brought down the cost from $11 at the time to about $3 per ampule. And then in 2024, all this work, along with catalytic procurement along with the price reduction, led to KEMSA, the Kenyan Procurement Agency, releasing their first ever tender for caffeine citrate. And by 2025, the government had committed its own domestic funds and released a follow-on tender of 165,000 ampules. So we could see over the past few years consistent growth in procured demand or funded demand for caffeine citrate. And also, as far as like the footprint and access across facilities, we saw that fewer than 10 public facilities had caffeine citrate before we started this work. And by 2025, over 100 facilities were trained and had caffeine citrate in stock. And I think something critical as well is that this work in Kenya also led to progress across other markets. So the price reduction was extended to other countries as well that CHI was supporting. And this has led to also increases in procurement volumes. And then we're also seeing additional manufacturers enter the market as well and pursuit of WHO PQ for caffeine, which will further accelerate registration across the African markets. So that's the case study in Kenya and some of the work that has happened in other countries. I'll hand over to Devin to talk us through specific progress across our 10 countries.
Thanks, Musli.
Next slide, please.
Thank you. Yeah, and the progress in Kenya that Musli just talked us through reflects a broader momentum, as she mentioned, and governments across 10 countries have now taken steps to introduce and scale caffeine citrate. And CHI has been very proud to support our government partners in that work. Across all 10 countries, governments have been working to establish an enabling environment, so getting caffeine citrate onto essential medicines lists, into standard treatment guidelines, into training packages and procurement systems, and government tenders have now been issued in 6 countries, which reflects a meaningful transition toward domestically funded procurement of caffeine citrate. The table on this slide shows where each country stands across some of those key enabling environment indicators as of the end of 2025. And while there's still progress to be made, the direction is just really encouraging. And we're hoping this work contributes to momentum across the broader newborn care agenda. We see it as one proof point for what's possible when market barriers are addressed systematically. So hope this has been a helpful overview. We're happy to take any questions at the end. Thank you.
Thank you. Thank you so much, Devon and Musleehat. You've done remarkable work speaking about caffeine citrate coverage in caffeine citrate in government finance markets, the expansion with CHI. You've been able to showcase the remarkable work that CHI has been leading in many countries where initially there were knowledge gaps, caffeine was missing in the essential medicine list, despite the fact that it's a very recommended clinical advantage over aminophylline for apnea of prematurity in the newborns. Then CHI has led in increasing market visibility guidelines updates, ensuring demand generation and investment, and has leveraged the global momentum. And this has been quite catalytic because I know in Nigeria, we've worked with the CHI team, with the Federal Ministry of Health, subnational governments, other partners and professional associations to develop what is a document called Roadmap for National Scale-Up of Newborn Care Commodities in Nigeria. Thank you so much, Levan and Musleehat, for that very insightful, remarkable work. So now we'll shift over to the clinical arm, and we'll have Dr. Cathy speaking about caffeine citrate coverage in next 360 countries and policy shifts in Malawi. Dr. Cathy is a Malawian medical doctor. She's a clinical director for Next 360 Malawi. Dr. Cathy has rich experience in maternal newborn health, clinical service delivery, and health service management, advancing quality and coverage of care for small and sick newborns nationwide. You're welcome, Dr. Cathy. Thank you. Over.
Thank you so much, Prof Chinyere, and thank you for the Newborn Toolkit team for this opportunity to share on the Next 360 countries, and specifically I'll go deeper into what's happening in Malawi in terms of caffeine introduction. So before I start, I think just a snapshot of Nest 360. So we are in 5 countries in Africa, and we have been implementing government-led interventions that have been also very data-driven. And this year, I think we'll be engaging quite more and sharing a bit more of the experiences that we've seen across the 5 years. And we're happy to share, especially in Malawi, that we're seeing significant mortality reduction through the bundles of care that we have been implementing. So next slide. Right. So I think across the Nest countries, we have also adopted the use of caffeine as first-line treatment for apnea of prematurity. So I'll not go specific into the details, but we have mostly caffeine and aminophylline. And we will be sharing, I think, the coverage that we're seeing based on the Nest 360 data and analysis that we did from a health facility assessment. Next slide. Right. So in 2023, we conducted a health facility assessment after we had been implementing for a few years. And this slide is depicting the availability of caffeine. So either oral caffeine on the left and availability of IV caffeine across 4 countries. So Kenya, Malawi, Nigeria, and Tanzania. If you see, there's a lot more red, especially on the oral caffeine. And this at the time in 2023 was during the assessment, either not available on that day or available but stocked out in the last 4 weeks for the yellow, and then green if it was available and there were no stockouts in the last 4 weeks. So for the oral caffeine, we're seeing more in Nigeria, seconded by Tanzania, then Kenya, and then 0 in Malawi. So I want you to also take note of the coverage in Malawi and availability, because I'll share more of the progress that we've made in the last year. So to caffeine IV, available, I think, mostly in Nigeria at 72%, seconded by, I think, in Kenya at 46%, and then in Tanzania. And of note, maybe other counterparts from Nigeria can also share. I do know that they do reconstitute the adult formulation to be used in the nurseries, but we can learn more from the Nigeria team as well. But of note, Malawi had no caffeine during the assessment, and even without caffeine, where we're using aminophylline as a country, 11 out of 38 of the hospitals still reported stockouts of the second option, aminophylline. Next slide. So now I'll be sharing, I think, the coverage of the different drugs to treat apnea of prematurity over time. So starting from Q1, Q1 2021 to Q4 2024. And if you see at the top left, we have Kenya. They are still using both aminophylline and caffeine, but we do see a rise in the usage of caffeine. Also, when you look at Nigeria, they have quite good coverage of the caffeine usage across the years. If we look at Tanzania and Malawi, both started off in the years, I think, with minimal usage of caffeine, really. And I think lately in 2024, 2023 rather, there's been introduction in Tanzania of caffeine into the standard treatment guidelines, but also being fitted into the market. So I think, as you see the graph where there's caffeine, the green, seeing, I think, more of the usage in 2024, and that will dip, I think, will rise up, I think, as they continue to implement and standardize or sustain the availability in the country. And then that leaves Malawi, where we're still using aminophylline. Next slide. So this is just the overall coverage across those same years, where we're having the caffeine coverage, where the indicator is really use of the caffeine out of the neonatal admissions with less than 34, gestation age of less than 34 weeks. So once again, we're seeing the most caffeine citrate coverage in Nigeria, 96%. And even the overall coverage at 90% for the babies that were able to get treated for apnea of prematurity, seconded by Kenya, where 40% were able to get caffeine out of the babies that were treated for apnea of prematurity. Of note, because the indicator denominator is using gestational age, we did see during the analysis missing data in terms of the babies that actually had accurate gestational age, or even had the gestational age defined, even if it wasn't defined, maybe it wasn't documented. So we're also seeing an aspect of poor data quality or capturing to be able to also define the coverage across the countries. Next slide. All right, so moving on to Malawi. So as you've seen from the data, there is zero usage of caffeine as a country, though despite that, I think we do agree and have adopted it as the right first-line treatment for caffeine. So now what has happened in Malawi in the last year? So 2025, we have seen a lot of fast movement towards adopting caffeine into our guidelines. So NEST 360 has also played quite a crucial role in terms of supporting technical capacity of the Reproductive Health Directorate under Ministry of Health. So we sat together, supported the ministry, and they adopted it within their country policies. And moving from there, we also supported the presentation of its use to the National Medicines and Supply Committee. Now we're happy to say, as Chai had already depicted in their slides, that it's been added to the essential medicines list and the guidelines and trainings. I think there was also a lot of support from Chai to develop these, and technical capacity coming from the NEST 360 point. So we did have guidelines under the pediatric NCD guidelines, but we are trying to align all the guidelines so that the Malawi Standard Treatment Guidelines and COIN are depicting capturing caffeine use. Now, in terms of supply chain, we've seen a lot of movement after the introduction of Beginnings Fund, and really happy to have Chai on the call today. The team in Malawi has been super. I think I do have a room somewhere in the Chai offices where we sit. We've been pushing, for caffeine to be made available, the different committees to come together and actually accept and adopt its use. So support from Chai, and also as of this week, I'm happy to report that caffeine has been added to the Central Medical Stores catalog. It has its own code, and there's a tender that has gone out for suppliers. So the presidential initiative will support that on maternal health to introduce caffeine. So we should have some suppliers should be able to now start bidding for its introduction into the country. So we will partner. We've had some suppliers coming into the country to tell us about the products that they have. An example is Chiesi, who have also been embedded into the talk today. So we'll hear more about how they're supporting countries, and we're really happy if we can have such organizations. Chiesi, I think FD Farm has also pitched in Malawi, but we'll be really happy if Ministry of Health could get this support so that we bring the product into the country. And then in terms of implementation, we have a lot of technical support through the different associations, and leading as a pediatric association for Malawi. And they will be, I think, quite key together with the nursing midwifery associations to deliver the training packages and also ensure compliance within the facilities. And now we also want to look into, like, our counterparts in Nigeria. I mean, could they be options for local formulation or mixing in central hospital pharmacy units? Also a potential area that we want to explore. And lastly, to also improve measurement of the coverage and the quality. So as NEST 360, we would want to incorporate this into our existing dashboard to be able to measure to support not only Malawi, but the other countries as well. Next slide. Okay, so looking ahead, we want to move faster, but not faster alone, but faster together. So all partners that are in the caffeine space that have supported other countries, Malawi would be happy to have your support. We want to improve the supply chain and also make sure that it is sustained. So through market shaping and price reductions, as Chai has already presented, and also exploring other practices that are happening in other countries, maybe local reconstitution of maybe adult formulations. And as we do start implementing as a country, we want to learn as much as we can and also share across the countries, say through the toolkit. Next time we come, we hope you will not see red, you'll see more green in our graphs. And then, yeah, we will improve routine data use, coverage, quality, and measuring also the impact. So we want to be able to also incorporate quality of care cascades like timing of administration. We've done the same, I think, for interventions like CPAP as well. So not only just giving the drugs, but at what point, was it given? And then also pair it with antenatal corticosteroids, CPAP and KMC. And then finally, to improve on the data quality so that we can capture the true picture of what's happening on the ground. Next slide. All right, thank you so much, everybody. I want to give a special thanks to the team that supported me on the analysis, the team at London School and also NEST 360, and also my fellow country directors and country leads for sharing their experiences on caffeine in the other countries. Thank you so much.
Thank you so much. Thank you so much, Dr. Cathy, for that brilliant presentation. And big congratulations to Malawi, starting from initial almost zero utilization of caffeine to have made tremendous, remarkable progress over the years. And you had spoken about the other countries who have more advanced use of caffeine, like Nigeria, but also that not only do we have to move, which is key, not just moving alone, but moving together and moving faster. That now the caffeine in Malawi is in the Central Medicines Catalog, where to also explore local formulations, in working together with other partners like Chai, Chiesi, etc. And that is so remarkable that we should bundle antenatal corticosteroids with caffeine, looking at CPAP, looking at KMC, as a bundle together. Thank you so much again, Cathy, for that very insightful presentation. And Cathy in her presentation mentioned market shaping. And next on the list for this team of experts for this very critical webinar is Chiesi Foundation. Let me introduce Linda. Linda Storari is Vice President Global Department in Chiesi. In recent years, she has focused on establishing a global health department at Chiesi Pharma, aimed at introducing high-quality essential neonatal drugs in sub-Saharan Africa through an inclusive business model, which we're seeing playing out in this presentation. The Chiesi Global Health Initiative also supports capacity building efforts to strengthen local healthcare systems and improve outcomes for newborn. Welcome, Linda Storari, to this webinar as we learn what the remarkable work that Chiesi is doing. Thank you. Over.
Good afternoon, and thank you for the very generous presentation. And it's a pleasure to be here to be able to talk about our sustainable business project for sub-Saharan Africa. That is with our Peona caffeine citrate 60 milligram vial formulation. As mentioned, I am Vice President of the Global Healthcare Department, and it is a pleasure to be here. Next slide. Thank you. I think it's very important to start by briefly describing the company I work with, because this is, I think, what really makes it special and allows me to do this project. So our company was established in 1935. It is a family-run and family-owned company. It is a benefit corporation. And for those of you that are not familiar, this means that we are a legal profit corporate entity, which we commit to generating material positive impact on society and on the environment alongside profitability. And this is why we talk about a sustainable business project. The company is a relatively large company. I'm talking to you from our headquarters here in Parma, but we have over 30 affiliates, and our products are available in over 100 countries. I'm very proud to say that we also have 7 R&D centers, and we invest approximately 1 billion euros a year in R&D, and 2/3 of our employees in research are women. So very important numbers. We focus on 3 main areas, which we call air, rare, and care. Air is so we focus on drugs for respiratory diseases, also on drugs for rare diseases. But today I'm talking to you about our portfolio, which is on neonatal drugs, and specifically for babies which are born premature. So in Chiesi, we work in the area of apnea of prematurity and also RDS. Next slide. So a few words about our department. Our department is relatively new, and we are committed to reducing neonatal mortality. How do we want to do this? By expanding equitable access to life-saving medications. We're starting with caffeine, but in the near future, we also want to introduce our surfactant, Curacef, for the small and sick newborns across sub-Saharan Africa. How do we want to do this? By an inclusive business model, which is designed to ensure long-term affordability and availability of quality assured medicines. This is not philanthropy. This is a sustainable social business program. And we also believe on the importance through strategic partnerships in investing in strengthening health systems so that these therapies are administered by well-trained personnel within facilities which are equipped to provide appropriate high-quality care for the sick newborns. Next. So the pillars of our execution. So affordability. Just to give you a concrete example, when we entered the first market, Ethiopia, in 2025, we were able to reduce the cost of therapy by approximately 90% compared to the competitor. This was very important because, as you all know, unfortunately, many parents have to pay out of pocket. And for the first time in Ethiopia, many parents were able to afford caffeine therapy. So this is something which we are particularly proud of. And then obviously, as we also saw in other presentations, consistent product supply by also selecting carefully our distributors, but also by a well-structured logistic department, which we have here in Chiesi. Our products are all EMA approved, and we are also entering the markets through WHO regulatory processes. So this product was first approved in Europe and is now being introduced into sub-Saharan Africa. And then we have limited commercial margins, which we reinvest in co-designing system readiness interventions to strengthen the healthcare system in delivering these quality neonatal care, including neonatal drugs. And we do this with multi-stakeholder partnership. We know how important it is to partner locally with the governments, with the parents associations, with the clinical communities, the importance of working alongside the pediatric associations. Next. So we realize that no matter how clinically effective, drugs will only work if they and will save lives if the surrounding clinical and system enablers are functional. Therefore, for us, it's very important to have an enabling environment for respiratory medicines. So as we enter new geographies, it's not just about finding a new distributor, but it's much more. So it's about policy, national protocols and guidelines, financing, human resources, infrastructure, facility readiness, looking at the equipment and the commodities, and data. And there where data is not available, we are supporting pilot projects to collect data. And to give you an example, in Zanzibar, for the first time ever, we did data collection on understanding neonatal care in all 14 hospitals. And we delivered this record to the Minister of Health in 6 months. So it's a lot has to do with data collection as well. Next. So in Chiesi Global Health, we do not see ourselves as a simple drug supplier. We like to think of ourselves as a catalyst for change, as an ecosystem enabler. So it's not just about caffeine and surfactant. Next. It's about the additive impact. It's about system integration. It's about being complementary. So having a holistic approach and having a sustainable approach. Only in that way can we make a sustainable difference. Next. So on one side, we have to ensure that our business plan is sustainable over a long term. So we have prepared a 20-year business plan, which we presented to the shareholders. So once we made sure that it was sustainable, we are now measuring the impact by the numbers of babies that we will be able to treat. So we have made some calculations that from here to 2030, we will be able to treat approximately 335,000 babies across 10 countries, with both Peona starting from 2025 and Curacao starting from 2028. And that by 2045, we will have reached and treated 4.3 million babies. And this is something which we know is very ambitious, but for us, it's a very clear objective. Next. This is my final slide to say where we are now. So Peona is now a reality in Ethiopia, where we launched in July 2025. We also launched in Tanzania in January. We will be going to Uganda on April the 17th to launch also there. And the next steps we are submitting for registration in Rwanda, in Malawi, at the beginning of next year in Nigeria, and we're about to submit our request for pre-qualification, which will also accelerate Peona. So this is my last slide, and just so next, I wish to thank you, Asante Sana, and it's a pleasure to be able to present this initiative. Thank you.
Thank you so much, Asante Sana, Linda. Merci beaucoup. We really heard from you about the remarkable great work that Cathy has been doing to expand equitable access to life-saving interventions, this caffeine. And you did that using an inclusive business model, which is key. And you also spoke about the 5 pillars. These are trying to fill out the gaps that caffeine has had all through across the globe. Especially in low and middle income countries, we are looking at the affordability, the pricing, the availability, the quality. You're able to get local investments and multi-stakeholder partnerships. Thank you so much again, Linda, and thank you. And then you spoke about Peona, which is coming on and with this ambitious target to reach 4.3 million babies by 2045. This is key. And this is all we're putting all together in this holistic change, in a sustainable manner. This is so crucial. Thank you again, Linda. So today, very distinguished audience, please put your names in the chat. We're seeing all the very, very wonderful audience. And thanks so much to the great, very brilliant, very enlightening presentations we've had, our presenters. Today, we've heard from Professor Josh, who spoke about who set the pace with the WHO antenatal corticosteroids, and we went on to Chai, Devon and Musleehat that spoke about expanding access to caffeine citrates. And we looked at the clinical with Cathy Magombo giving us the how far they've gone in Malawi, which is remarkable, and then other countries. We went on to Chiesi then, who spoke about private sector initiatives, looking at the affordability, the feasibility, and that accessibility, which is key. And all through this presentation, we've heard moving faster together, catalytic change. We've been working so hard on other interventions to promote newborn health, but how do we bundle them? How do we have this sustainability? How do we put antenatal corticosteroids? How do we put caffeine citrate as fundamental interventions? Bundling it with caffeine, bundling with the CPAP, bundling with the kangaroo mother care in that sustainable manner. Thank you so much. Please, we're looking at questions and comments in the chat, and we've put links in the chat. And also to thank you so much, everyone. We've also put links in the chat. Kindly put your questions. There's some that have been answered by Prof Joy and the Chai team. And we're looking forward to all the subsequent webinars. Thank you so much for joining us today. Huge thanks to all the speakers. The webinar film will be available soon and shared on our social media platform. Please watch out. You can please sign into the Toolkit newsletter, where we're looking at multi-stakeholder, multi-country, multilingual learnings to improve care for small and sick newborns. Faster together for every newborn is the mantra. Thanks so much everyone for joining us today. And looking forward to you joining in other forthcoming webinars. We also have one on kangaroo mother care. Thank you. Funders, very good. Thank you to our funders of the Next 360 Alliance who are listed here. Thank you so much, Gates, Elma, Sif, Mohammed Bin Foundation, Beginnings Fund, Sal Family Foundation, private donors under agreements with the William Marsh Rice family, funders of the French Toolkit, Casey Foundation, Merci beaucoup to Lemon, Toolkit Expert Advisory Team, and the Toolkit team that is based at the London School of Hygiene and Tropical Medicine, led by Prof Joy Lon. Greetings, everyone. So looking forward to having you all together. We're also hoping to see many of you at the International Maternal Newborn and Health Conference coming up in 2 weeks. And because this is a place to also showcase a lot of work that's been done in these newborn interventions. Bundling, today we've heard about antenatal corticosteroids. We've heard about caffeine citrates as key interventions that has evidence-based to reduce morbidity and mortality in preterm babies. Thank you, everyone. Over to you, Lauren. Thank you.
Thank you, Chinyere. The recording for all those who are interested should be available on the Newborn Toolkit site this week. And with that, we'll close the webinar here. Thank you.
Merci beaucoup. Merci beaucoup, Lauren. Merci beaucoup, tout le monde. Thank you.
Thanks all. Bye.
Bye. Bye-bye. Thanks again to all our wonderful presenters.